Hello, everyone. Welcome to today's CalMap webinar on Small Moments, Big Impact, Relational Health and Healthy Mental and Emotional Development. We're really glad you're here and able to make it out of your really busy days. With that, let's go to the next slide, please. So quick reminder for those of you who don't know, CalMap does offer free curbside consultation with child and adolescent psychiatrists, as well as with psychologists and social workers and care coordinators. You can get free, almost real-time advice on how to diagnose and manage common mental health conditions in primary care. So please do give us a call whenever you feel stuck. Next slide, please. Also a reminder about some of our upcoming educational offerings in April. It's Substance Abuse Month in our webinars, as well as in our primary care echo and school echo. Hope to see you there. And a reminder of our skills echo, where we'll be talking about distress tolerance skills based in dialectical behavioral therapy. And with that, I'd like to introduce our speakers for today. Dr. Cyndie Hatcher is a primary care physician who completed her medical degree at Harvard Medical School and her public health degree at the Harvard School of Public Health. After training, she became an attending physician at Boston Medical Center and assistant professor of pediatrics at the Boston University School of Medicine, where she continued to research innovative practices to improve health outcomes for children. In addition to running a team-based care pilot program, she co-developed Small Moments, Big Impact, an online tool that helps improve empathy and attachment within mother-baby dyad. She hopes to improve the provider-patient encounter by promoting conversations necessary for true relationship building and creating trusted connections. She's excited to share this tool with all of you today. Dr. Barry Zuckerman is professor and chair emeritus of pediatrics at Boston University School of Medicine. He is a national and international leader in child health and development. Dr. Zuckerman and colleagues developed 4 highly influential programs: Reach Out and Read, Medical Legal Partnership, and Health Leads, and Healthy Steps, along with Small Moments, Big Impact, which have all had a national impact. In addition to more than 250 scientific publications, he has edited 9 books, including 5 editions of Behavioral and Developmental Pediatrics, Handbook for Primary Care. None of the speakers or the organizers of today's event have any disclosures of a financial nature. And with the next slide, a quick word on some of our federal and state funders today. And with that, I will hand the virtual mic over to Dr. Cyndie Hatcher.
Hello, everyone. Such an honor to share more about relational health in this passion project that I have. Dr. Zuckerman will be joining us, but he's just a little bit delayed. So I hope that by the end of this talk, you will be able to critically assess the current standard pediatric practice and diagnose a potential missing component in our standard care, analyze the biological implications of childhood psychosocial adversity and the role of early relational health and the utility of a relational health tool, and hopefully be able to integrate the Small Moments Big Impact tool within your practice. So I want to think about what pediatric care looks like today. And I know we have individuals from multiple disciplines in the pediatric support model, but in primary care pediatrics, it's become pretty straightforward. And so in my clinic, initially I would meet families 2 days or 4 days after birth, and they would show up with the newborn, and I would greet them, congratulations on your beautiful new baby. How are you doing? And I think all of you probably answered in your head just now. Fine. Okay. How's the baby feeding? Good. They're not latching well, or I'm not sure if I'm mixing the formula correctly. Okay. Who's at home to support you? They usually say something, and I scribble quickly and say, great. We go through and I look at the height and weight, and I have a 2 to 3 minute monologue on umbilical cord care and red flags. And then I look at our social determinants of health screen. It's negative. So Obviously, they have no financial stressors on that family. And I look at the postpartum depression screen, that's negative too. So clearly, this parent doesn't have any postpartum depression. I'm able to check off my check boxes, my best practice advisories by our ACO. And I tell the family, baby's doing great. I'll see you in a week for another weight check. And I'm out the room on time for my next patient. Did it feel like a little bit of an assembly line to you? Because it did to me, especially after doing that for a few years. I saw the thumbs up. So, I mean, imagine us doing things a little bit differently. Imagine the same family comes in for their newborn appointment, and I greet them. Hi, I'm Dr. Hatcher. Congratulations on your new baby. Can I show you a video while I log into the computer? And then we can talk about it afterward. Okay?
You're doing such a good job.
Yeah, I try.
He's beautiful.
So then I look to you and I say, what was it like for you when someone special held your baby for the first time? And I'm asking that to all of you. Any brave person want to speak up or put something in the chat? What was it like for you? Thank you. I see like nothing I've ever experienced before. Emotional. Absolutely. And I find when I ask this question, the responses I get are so diverse, and I'm always surprised. Wanted them to give her back. Yes, those instincts kick in, right? I remember I showed this video to a family for the first time, and I asked the question, but dad was in the room. And so when I asked the question, we all kind of thought, okay, well, let's just look at him. Well, what was it like for you holding your baby for the first time? And he looked up and said, it was terrible. Here we were surprised. And he went on to say that while the birthing process was happening, it got really dicey. And the heart rate went down, and there was blood everywhere, and people ran into the room, and all these medical people told him that there had to be an emergency C-section and gave him clothes to change into to go into another cold room. He said that he thought that he was going to lose his best friend and his baby all in one fell swoop. And so he started praying and making deals that if anyone had to go, it was maybe the baby, because then he'd keep his best friend. Well, suffice to say, he walked into the OR and couldn't talk to his spouse because they were getting oxygen and barely heard the baby cry when the baby was pulled out. Got scissors to cut the cord, doesn't remember that. And then someone put the baby in his arms, and he was still grieving the thought of the loss. We're listening. And his partner looks at him like, I didn't know that. They hadn't talked about it. This is day 4 and they hadn't talked about it. And this was a really powerful moment for the both of them, starting off as new parents and being able to connect on how emotional and how much things change just with the introduction of a new baby, and the trauma that may be involved in bringing that baby into the world. As you can imagine, that visit was different. I really got to know that family. And every visit from there was no longer surface. There wasn't a fine, there wasn't, these quick check boxes, but we really had deep discussions about what parenthood looked like for this family. So many of you are likely familiar with the AAP policy statements. This is the most recent one. There was one previously in 2010 talking about childhood toxic stress and the ACEs. And so this is a response and it's solution based. So what is the solution to the childhood toxic stress that we all talk about? And it is promoting relational health. We know now, with recent neuroscience, that childhood psychosocial adversity affects the child down to the DNA level. And so you have a changed developmental trajectory, and it increases that child as they grow into adulthood of disease. So either social problems, cognitive defects, and on a myriad of diseases. And I think this science just reminds us the important implications of childhood toxic stress and why a solution is important. So I'm not sure if Dr. Zuckerman has been able to join us yet. No, okay. So I want to share a video with you demonstrating, the child's interaction with the caregiver and how in tune children are with their caregiver. So you see here a mom engaging baby. So there's good eye contact. She's giving stimulus and the baby's responding in suit. We asked mom to turn around and now to keep a straight face, not to respond to her infant. So he makes the noise like, hey, mom, we're playing, right? She doesn't respond. You see, he turns away. It's a sign of distress. He starts tugging at his clothing as well, also showing some distress. As it escalates, he gets more upset. You see his posture changes. And he tries to get her attention. Here he yawns, which is a sign of distress. This is not fatigue. It is very difficult to watch. We then ask mom to turn around and re-engage baby. And this is what we call repair. So you can see after a brief period of repair, they can start to pick up where they left off. So in that video, you got to see an engaged parent who's able to participate in interaction with her child. See another family. All right, see if I can play this.
You want to play patty cake again next time, huh?
So in this
You wanna play
video,
patty cake? No, you want to play with the turkey? Huh?
we're not sure quite what issue mom had before, but there was very little engagement with the child. So now this parent is asked to engage the child.
Oh. You want to play with that? You gotta play with that? Huh?
Has Dr. Zuckerman
You
joined?
wanna play with that?
Yes. Took me a while.
Perfect. I heard you log on.
You mad at me? You mad at me?
You can pick up Dr. Zuckerman.
Okay, good. Let me,
Plant your feet. Paul. Paul.
can you hear me?
You ain't even interested
Yes.
in me today.
No.
Paul.
Can you hear
You
me?
want to play with mommy today?
Cyndie,
I can hear you.
me?
I can hear
Okay.
you.
Let me just make a couple comments about the
Yes.
videos.
Perfect.
Since I was there from the beginning of them. The first video, that interaction with starting with the mother going back and forth, looks perfectly normal. We all could just smile. but there's a lot going on. And one of the things is that the baby's in synchrony with the mother. So when the mother smiles, the baby doesn't. And of course, when the baby smiles, the mother doesn't. So the baby's learned, and I use the word learn to underline with this practice with the mother to take turns. Very subtle, but it's a, if you will, a cognitive thing to go along with the emotional aspect of it. Then with the still face, why does the baby get distressed? Well, the baby gets distressed because, again, from a cognitive point of view, they've already have an expectation that if they smile, the mother smiles back. And then there's obviously a disappointment, as all of us, when we have an expectation of something special and we're disappointed. Then with the last one, the mother works a little hard to get the baby's attention, but the clinical point of that is called repair. So when a mother is driving a car or cooking and can't respond to the baby, it's important to circle back, because if the mother doesn't circle back, and this, if that still face happens, regularly, and the mother doesn't circle back, the baby doesn't think they're important. So, over time, that's where we get into really some of the severe mental health aspects. And in this video, if you look at, mother and baby are just not connected at all. We assume it's partly that the mother is depressed and hadn't developed the kind of reciprocity and expectation that you saw. If you think that the baby's looking at the camera or something, that's not true. The baby is actively looking away from the mother. So things aren't going well. So let me just pass it back to you, Cyndie, and I apologize for being late. Couldn't get on.
Thanks so much, Dr. Zuckerman. So what is early relational health? This is the quality of relationships a child forms with their primary caregivers. Exactly what we were just talking about, this a relationship with the caregivers that's reciprocal and synchronous. So you may hear the term safe, stable, and nurturing relationships. And so this explores the development of these safe, stable, nurturing relationships across the child's life course. It does involve childhood attachment, emotional support, communication, and consistency and stability. So the AAP has a toolkit for promoting relational health that you can find on the website. And I just took this table from it, and they're talking about a public health response to relational health. I think we can all conceptualize promoting relational health by seeing parents. So this involves getting to know parents, understanding what the barriers are to safe, stable, nurturing relationships within their lives, and then pointing them in direction of supports to help repair strained and compromised relationships. What I want to talk about is small moments, big impact, which helps with those things. So Small Moments, Big Impact is an online tool to help promote relational health by stimulating conversations. These are the conversations that we need to help support that caregiver-child relationship and to understand what barriers or challenges this family has. It provides a model for open and honest communication. When you have open and honest communication, we all know that you can expedite relationship building and build a partnership with families at the critical development time. So I want to give you examples of how I use small moments, big impact in practice. So I do use the videos during the visit. So like the video I showed you earlier of the dad holding the baby for the first time. At the beginning of the visit, I'll play the video and I'll ask the parents their response. So this video, this is advice from grandma.
What's that? What's that? Huh? What's that?
Say, meet my grandma.
Whoop, whoop.
Grandma just lets him be the bad boy that he wants to be. It's just like she brings the bad boy out of him. Let him do what he wants.
DJ, wanna go bye-bye? Let's go. Let's go.
So, you know grandmas. Let the babies do what they want.
You should let him do it. Don't help him. Don't help him.
Grandma don't want me to help you.
No help. Get it. You're walking on the table.
Go on. There you go. Keep going. One after the other. There you go. Yep.
I'm not sure if everyone heard that, but the grandma says to the mom, like, don't he's walking on the table. Don't help him. And she gets a little bit upset and storms off in the background. So I ask families, have you ever disagreed with a loved one's advice? And I'll ask you all, anyone brave enough to add it to the chat or speak up, have you ever disagreed with a loved one's advice? I'm getting a lot of agreement. Anyone care to give an example?
Most people can't unmute because we're in
Oh,
webinar format.
oh, I'm so sorry.
And so it's
That's
all
helpful. Thank
gonna
you.
come through the chat.
Yes, no, that works. And I see in the chat someone added corporal punishment. Absolutely. And I will say that I had played this video for a family. The child was 4 months old and had significant health issues from birth on, and so I hadn't played any videos for them. But mom had showed up with her mom for every visit, and I had previously thought that this was a supportive relationship. Like, how great your child is dealing with some significant health issues, but at least you have someone to join you with all of these specialty visits and to support you at home. I played this video, um, rather tongue in cheek, and mom refused to answer. At that point, I read the room and asked grandma to step out. Mom then let me know that it's been terrible at home because the baby's health issues were her fault. It's what she ate during her pregnancy, and she worked during her pregnancy. And so she's the one who caused him to be ill. And now that the baby is out, everything she feeds him is wrong. Everything she does is wrong. And the only reason this child has ever had a chance of health was because grandma's there. And you, Dr. Hatcher, and she pointed to me, you make it worse. Every time we come to these visits, you agree with her. And the whole car ride home, she berates me and says, see what the doctor said? I was so humbled and mortified. So I said to her, I'm so sorry. I had to apologize. And okay, moving forward, how can I partner with you so that you're the parent in the room? And so she said, all right, Dr. Hatcher, as long as I don't say something crazy, can you just agree with me during the visit? No problem. I can do that. And, we asked grandma back. And so the visit was totally different now. Like everything mom said, I'm like, wow, that there's studies that support that, right? So I'm boosting mom up and we have a totally different visit. And so suffice to say, this child did end up having some exceptional needs, and mom became the biggest advocate for this child. We had a few more visits with grandma, and grandma no longer joined the visits after that, as mom got her voice and was able to stand up for herself and her child. And I was really humbled that I would have never known if I hadn't shown them this video and had this conversation. And it reminded me how important it is to start to connect with families and continue to on a human level, that my assumptions were wrong. This was not a supportive relationship for her at that time. And it was really incorrect of me to assume, but better for me to ask and talk to her. I'll show you another video.
I'm too tired. I don't even want to do nothing. Sometimes he wake up and he cry. I'm like, go to sleep back. Yeah, 'cause I'm too tired. But I feel good being a mom.
Yeah, mi amor.
I don't know. Sometimes I don't even want to wake up from the bed. I just stay there with him, and I take a shower like in the night. When the daddy's here, so he can take care of him, I be sleeping with him the whole day.
Mi vida, ya, sí.
He stay there the whole day if you leave him. He drink a bottle of the milk, and then he drink the breast. Sometimes I feel alone, but sometimes my mom, she's helping me a lot. Because some stuff that I don't know, I ask her because she have 4 kids. She helped me. Yeah, I have like 2 or 3 friends. I don't have like too much friends.
Ay, caramba.
From the beginning, I feel like it was difficult, but now I feel like everything is getting together. I feel better now than before.
So I'll ask families, can you relate to this mom's exhaustion? Who can you call for help when you need it? This mom in this video is so exhausted. You can see it. She's a little bit dysthymic. She's better now than she was before. And she says in there about, man, sometimes when the baby cries, I wish he would just go back to sleep. I just want to lay in bed all day. I, I, I have found this video has been more sensitive in picking up on moms expressing things like this than my Edinburgh postpartum depression screen that I often get back, and it's completely negative. And then you talk to the parent, and the parent's really dysthymic and really down and just dragging. And so then I'll play the video, and I've had so many parents say, "Oh, I can say that? Oh my gosh, I just want to stay in bed. I'm not sleeping enough. You know, that's why I'm tired. I'm not depressed. I can't get enough sleep with the baby because I'm just worried, you know, I don't want to miss anything." And we start having conversations where they get to speak, you know, that say the silent things out loud, you know, bringing up all the worries that they have and, you know, the scary thoughts they have, which our current medical model does not elicit. It really doesn't offer opportunities for parents to be open and candid about the challenges of parenthood, especially when they're emotional and they're not pretty. Show you another video. So I'll usually ask, what are your thoughts? I know everyone can go in the chat, so I appreciate if you can put things in the chat. What do you think the baby is feeling in the video? I see that he's trying to get attention. Love me. And what do you think mom is feeling? They both seem bored. Pooped, yes. I need a break. Absolutely. So I played this video for a couple, and so I asked the same questions I just asked you all. And mom started to answer and then stopped herself, and her spouse answered and said, well, you know, it looks like mom's exhausted and probably needs to respond to an email or something. She's finally got a moment to herself. And I turned back to mom, and she had nothing else to add. And so we talked a little bit about repair, as we all talked about earlier today. And then also, you know, being thoughtful about our media use in front of our kids. But we all recognize there are times you cannot respond to your child, whether you need to respond to an email or cook or drive, and that you can repair afterwards. And, you know, we ended the visit, and I thought we were done. And then I got a MyChart message. And it said, I love that video you showed us, and I have more thoughts to share. I thought about it all day and all night. My husband and I are both spend too much time on our phones. A great reminder to be careful of that and to remember to remedy it with lots of love and attention after. By the way, I hesitated to answer about the mother because my first instinct was to say neglectful. But my husband started saying exhausted, and I was immediately made aware of the harsh judgment I had made. Like, I judge myself that harshly, apparently. Good to know he doesn't see me that way. And I see now I really should have more love for myself and other moms out there. I couldn't say it better myself. The videos also are really helpful for families who wonder, what should I do with the baby during the day? What is a developmentally appropriate way to play or interact with this child at this age?
I feel he's communicating, he's talking, he's speaking to me. He's saying something. So I talk to him, I imitate what he has said. He repeats, he makes a sound, implying that he understands there's a communication going on between the two of us. When he's happy, he's free, like after bathing, and he's not crying, he's not hungry, he'll start talking, and there are certain sounds he makes on a daily basis. So I'm like, I think that's his language. I respect his language too, the baby language, and like, oh, and you repeat, oh. Have it. I don't want him to only speak English, learn English. No, he has to know his culture, where his origin is, his parents are from. So, because we have culture, so I want him to learn Luganda. He can speak English in school with everybody around, but he can also speak to his relatives. But if God would help me, I hope to help the needy. I want to help people who are really doing so badly back home in Africa. The young children who have lost their parents. Sometimes when I'm breastfeeding, I even forget my problems. I forget my problems and I concentrate on the baby, and I'm like, oh boy, you're going to be great. You're blessed. You're going to be a powerful man. You should speak good things upon your baby, and then there will be those things.
So this, articulate mom, she's able to verbalize just how she interacts with her baby, but also demonstrate it and create a model for other moms. The other, I want to make sure we have enough time for questions, but I want to show you this video of hopes and dreams. One thing that, as providers and as those in the pediatric space, we want to partner with parents. And part of that partnership is explicitly asking them, what are your goals? What are your hopes and dreams for your child? And I will tell you, I never asked that question until I started using these videos. And I've been astounded by how many differing answers I've gotten.
My hopes for Ernest. I want him to grow up and be what I couldn't, I guess. So I want him to go to school. I want him play football if he might want to, because he's already big and husky. Like, do something. I just want him to be a better person than I was. If he can be a better person than Mom was, then great.
So I show that video, and as you can see, it's pretty brief, and I'll ask parents, what are your hopes and dreams for your baby? And I remember one of the more poignant parents had looked up to me after I played that video, and she asked me, she said, real talk? And I'm like, yeah, tell me the truth. And she's like, I want him to live into adulthood. And I was stunned. And she went on to tell me how all of the men in her family either were arrested or incarcerated by adulthood or died due to gang or drug violence. And she's still living in that same neighborhood. And she's just scared. She's scared of him losing his life on the streets or getting recruited into the same gangs that her family has been in. I was stunned. We never talk about it. The baby was 6 months. And I had no idea that they were dealing with that she was dealing with this type of fear. This changes our care because I get to talk to our social workers. And even though, the systems that be are the systems they are, but we have the ability to advocate for our families when we know that we are partnering with them on a goal. And we pushed and pushed, and we finally got this mom out of the housing she was in into a new neighborhood. I saw that this family last year, and mom was like, Dr. Hatcher, listen, I got to start saving enough money because I think he's going to go to school. And by school, she meant like university. And she has big dreams for him now. I mean, the list is endless, but it's very different from what she was dealing with back then. And I would have missed it. I would have not known if I had not asked her. So the other piece of this, I talked directly about patient care, but I must say that the assembly line care that I was providing early on in my career was burning me out. I didn't really feel like I was making a difference. While I was making sure that everyone's height and weight was stable, and that they got their immunizations, I knew I was missing out on the big part of care. And it would take me several years to get to know the families. With these videos, I find that I get to know that family so well in one visit that when I see them over the course of the first year of life, my goodness, we're like family at that point by the end of the year. And it really boosts my spirit. I feel so connected to the work that I'm doing. I feel like I'm making an impact, even if it is just sitting and listening and allowing a parent to unburden themselves from the worries or the thoughts that they have. I can't fix everything, none of us can, but we can have a human moment with another human. We can sit and reflect how hard that is, and maybe sit in the difficulty of tough times together. They're just not alone. Leaning into the discomfort helped me recognize what it truly means to care for families. So, small moments, big impact. We do have a study out there, and you can find it online. In our study, 85% of mothers rated the content high or very high, and they reported more growth mindset, greater understanding of their baby's feelings compared to a match control. So, we're getting back to that relational health. So, how can you use it? You can find Small Moments on the iOS store. You can download the app. You can take a picture of the QR code. Because the app version is directly for user facing, we created a website to allow for any provider to use it within the clinical setting or parents to use at home. The website is also in both English and Spanish, and you can use the QR code as well. When you go to the website, you'll find suggested videos. So if you're going to use it clinically, we have a team of home health aides that use the videos as well, and a number of other providers. There's a suggestion for each of the visits: the newborn, the 1 month, the 2 month, the 4 month, so on and so forth. There's a reflection question there as well. There are also after visit videos. Sometimes I'll talk to families and then I'll encourage them to reach out to the networks by, hey, watch the videos, the after visit videos on the app or on the website. And we can talk about it later, and we'll talk about it the next visit, or they can talk to their family members or trusted someone's. We have a video library. So if you go to the website as well and you're thinking, I really want a topical video, and I often do that for families since I'm pretty familiar with the videos. And let's say you want to pick something that deals with depression or exhaustion or finances or immigration issues, you can find them all in the video library. We have videos on trauma. We have moms in recovery. So the myriad is pretty wide. So I want to be able to ask questions and be interactive. So I just want to summarize: relational health is paramount to our work as families. And this is a free tool that can help you promote parent-child relationships and build therapeutic alliances with families. And as an ending point, I think one of the things that to me matters is that trust that we build with families as we think about the work that we do and the advice we give. As our world has gotten so suspicious and people are really concerned about where information is coming from, the trust we have with families is so key. And having a tool that will help you build that trust on a human level is only going to make your work even more powerful. Okay.
That was beautiful. Thank you so much for sharing those videos. Thank you so much for sharing your reflections on these. As we're waiting,
Joan, can I just quickly add something?
yes.
Because sometimes people get confused. This is not like a how-to where you watch and learn something. This is a stimulus for a discussion with a parent. And particularly when you're just getting to know someone, particularly in a pediatric clinical setting, you have relatively brief visits, but this allows us to make a connection very early on, as you heard from Cyndie, and be more effective. Otherwise, pediatricians make connections maybe 2 years later, or if it's a second child and they know the mother. So the key is this should be used not only with a clinician, but also we advise mothers, they look at it with the baby's father, with a friend, with a relative, and talk about it, because that's why we put the reflection questions in. Thank you.
Wonderful, thank you for that. I was going to ask, in addition to this particular tool, which I know that many of us are going to be interested in using, do you have other tips on ways that pediatric primary care providers can promote relational health or safe, stable, and nurturing relationships in the context of primary care? What can we do, like in this day-to-day practice, to help promote stronger caregiver-child relationships?
Barry?
Well, I think, I go back when I first in pediatrics, we would talk about the mother-patient relationship. And, that's still addressed, but, there's been big changes in the last 40, 50 years since I became a doctor. We have boxes of Cyndie to fill out and all these things to do. And, I think people know how to do it. If you can make relationships with people, and I'd like to think most pediatricians can, it's just we've acculturated during medical school and particularly residency to do it a certain way. So, again, there are plenty of ways to get to know the mother's feelings and use that to support, her ability and availability to the child. I just think, the small moments is, again, a stimulus and a prompt, and that's why we did it. But it's not magic if you're not acculturated in the old points of view. Cyndie, I don't know if you want to say more about that, because you're pretty articulate.
I think practically, we have Reach Out and Read, where we come in with a book and we demonstrate a developmentally appropriate way to read or use that book with the child, right? But I think in practice, sometimes it ends up being transactional, where the book is just handed to the family, right? And so that then you miss that piece. Other things that we do, as we talk to families about social determinants of health. It used to be a conversation. It's become a screener, right? And so when we think about the ideas that we've had to try to support parents and caregivers in caring for their child, in practice, unfortunately, they don't end up landing and creating those conversations that truly are necessary.
I love the aspect of conversation starting and connection building that that this tool really helps to promote. And I feel like those moments are so special within primary care, and the families that you get to know are just so incredibly special part of being a primary care physician. And I love that this tool helps to jumpstart that. And speaking to the acculturation piece, another use, I'm not sure who's told me this because I didn't come up with this idea myself. I'm showing this to pediatric trainees and family practice, pediatric and family practice residents as a way of just getting to understand moms better and parents better and the experience of parenthood, just in the midst of like all the pressures that they face and parenting with the phone, like always at the ready, right? So it also seems like a great educational tool as well. I would invite folks, if anybody else.
Joe, let me add to that, particularly with residents. They've never, they heard, oh, the mother's depressed and, they're, stressed and this and that, but they've never heard the words from the mother. And these things, really make an impression. At least they know what's there beyond, the textbook descriptions. And also because we have a varied population of mothers, this really helps getting across when there are, cultural or racial barriers, which are, special potential barriers. So this helps bridge that also.
Agreed. Agreed. And I think part of it too is, especially as a trainee, you're just kind of afraid the parent's going to ask you something that you don't know the answer to. And so I think these videos do allow trainees to just lean into the hard. Parents are going to say something that you're not going to have an answer to, and you don't have to have an answer to it. And that's okay. Instead of avoiding those difficult things, because I do think that as a coping mechanism, we just tend to avoid those difficult conversations because of that.
One question did come in. Okay, we will make sure that you can get registered onto CalMap, and from that you will become part of our listserv and get future announcements like this, and we're glad that you were able to join today's. And I would also like to offer up the opportunity for those who would like to share something, either to type it into the chat or raise your hand virtually, and we can see if we can unmute you to see if you can just share with the group. I do see from here, with conversation comes opportunities to model holding space and expressing empathy. Yes, absolutely. So this is a conversation and not like this top down. This is what you should do, directive. Absolutely. Yeah, that modeling piece of infusing the visit, I guess the parallel processing, right?
Yeah.
Infusing the visit with the same kind of interaction that we would love to see more and more of within
Absolutely.
communities.
I also see a suggestion for that every mom should be offered a nurse-family partnership. I strongly feel this level of parenting support is needed for this mental health crisis. Agreed, Chandra.
Definitely, we need to bring support around families, and it's lovely when it can happen within the home, for sure. And OB providers can also start these conversations in pregnancy. Yes, it's getting out of our silos and working across different professional groups to try and bring that support around families. Absolutely. Thank you for these comments. I want to call attention also to the link that was dropped into the chat. If you want to get CME credit, please feel free to use this link, and you can also scan the QR code that will be here. And so please do that in order to check in for today and to get credit for today's session. And as we start closing out, I want to ask for any final words, just on this topic of promoting relational health, because both of you are such incredible leaders in the space of pediatric primary care transformation, created these really transformative programs for pediatric primary care. We'd love to hear any last thoughts that from both of you about
Yeah,
how it is that we build this motion. Yes, please.
No, thank you. I think at this, we really have a call to action, and we really want to recruit early adopters. So anyone that this resonates with you, you feel that this is important, we would love you to join us to, start using these videos in your practice. I know there are a number of people here that are not primary care physicians, but maybe you care for children and families in different ways. And we are open to learning about new models of using these videos. As a point, I do want to say that I've had push from colleagues to just use the reflection questions only. And so some of you may think, can't we just use the questions instead of the videos? And it turns out that it doesn't work the same way. The video provides a model of vulnerability and asking the question. I've tried it myself, and a number of my colleagues have tried it. You still get surface answers because patients will tell you what you want to hear. Families will tell you what's safe and socially acceptable. When you provide the video, you create a model of being open and vulnerable. And so there's a difference there. So I would really love anyone who's listening, if you want to try these videos out, try it once, try it twice. I think you will find how it changes the tone of the conversation, and you will still be able to get the things done that you need to get done, but it'll be way richer. And you can join the change that we're hoping can happen in childcare.
Yeah, let me just add one other quick thing. the other thing, when you first start doing it, at least in a clinical practice where time is limited, it's gonna be a little difficult. Cyndie could tell you it took her about 10 patients until it became part of a routine. So don't get discouraged if you use it 2 or 3 times and it takes longer and you don't know what you're doing. The other thing is, if you can do it with other colleagues and then talk about what you're learning and how you're doing it, that becomes a really, important key. And for any of you who are in a group, with clinicians of any sort, whether you're home visitors or primary care clinicians, if your group is interested in this, we're happy to make presentations. And then we also suggest, a 1-month follow-up, maybe with us, to really talk about what you learned and what the barriers, what's working, what's not working. So it is a process, but again, it's really training, at least health medical training. I think most people who become physicians, let alone pediatricians, have the skills to do this, to connect, and we just culturate it out of them. And so naturally they can do it, but they don't, just like they don't use, they start using medical language with people always hematocrit, they don't use its blood count. They'll say hematocrit, and people say, what's that?
It's true. There's definitely a quite a bit of unlearning that goes into starting to use these videos.
That's wonderful there. Part of my interest in inviting the two of you was really to expand even what we do here in CalMap. So much of our education has centered around treatment, right? Like, how do we identify, diagnose, and treat conditions? And that's a very important part of what we do in primary care. At the same time, I think that a pediatric primary care advantage is we can prevent a lot of things. There's a lot of prevention that can be done, and we're here at the front lines, and we're seeing families at these really critical moments. And here's the opportunity to help to start on a much healthier path.
So please spread the word, and we're available. This is how Reach Out and Read went, how the Medical Legal Partnership, Healthy Steps. I'm a big believer in early adapters and to work through, colleagues, as opposed to top down from administrative heads, which, as clinicians get something once or twice a week of what they should do. And, most of it, they would like to ignore if they can.
Okay. Well, wonderful. Thank you so much for coming to speak with us today with our audience. Thanks to all who were able to attend. And if you are interested, please do reach out, and I will put my own personal information into the chat here as well. And let's continue the conversation. Hope to see you at our next webinar on substance use disorders on April 3rd at the same time, 12 to 1. And take care.
Thank you.
Thank you, everyone. Bye.